Welcome to HealthCast Southeast. I'm Dr. Jeff Stone, a family physician for over 40 years, and I'm privileged to bring you special content in this second episode of our HealthCast. Our particular guest today is a pharmacist by training, but she goes a few steps further, and we'll delve into that today with Jennifer Saddanathan. Jennifer, welcome to HealthCast Southeast.
Thank you, Dr. Stone. It's a pleasure to be here today.
Well, we're glad to have you. As I was mentioning, the healthcare team is a broad one, and it's a part of this sometimes referred to as medical industrial complex, with emphasis on complex. And we're trying to make our audience a little bit less intimidated by that complexity. So I'm curious, you have a lot of letters after your name, and I know it starts with PharmD or PharmD. Can you tell me more about that? What are you?
Sure. So PharmD is quite literally a doctorate of pharmacy. So we go to school, undergraduate, and then we go 4 years to get our doctorate in pharmacy. After that, pharmacists can choose to go the community route, which is what a lot of patients are used to. So, Walgreens, CVS, any of your grocery store pharmacies or independents. You can do that after your 4 years, or you can go on even and become more clinical in nature and do residency programs, just as physicians do or some other health professions do. So I went on after my PharmD and did a residency. You do a general practice residency where you learn a lot of clinical things. You work very closely with physicians and medical residents, and then you can specialize from there. So a lot of clinical pharmacists actually do 2 years of residency. And I specialized in what we call ambulatory care pharmacy, which aligns really closely with primary care physicians. So managing chronic disease states, primarily I focused on diabetes, blood pressure, cholesterol, and anticoagulation, just to name a few.
Wow. So it sounds like you do a lot of teaching in this role. And I guess we'll come back to that title you have.
Yes.
Doctor can be confusing. But the teaching that you do isn't just to patients, it's to the whole clinical team, am I right?
Yes, so that's actually why I got into where I got into in the first place. I wanted to be an elementary education teacher growing up, always had a passion for teaching. Life led me towards pharmacy for one reason or another, excelled in math and sciences, knew I loved patients, wanted to help the community in a way that I couldn't in being in an elementary classroom. So I got into pharmacy and knew I wanted to continue to pursue teaching. And actually, when I did my residency that I spoke of earlier, it was a teaching residency at the University of Florida. So I have always had a passion for that and did a lot of teaching as my first job and then continuing on teaching in pharmacy school. And we always work with medical residents and teach physicians, nurses, dietitians, other healthcare providers.
Right. So do you teach patients directly, or is that something that's more a part of your team, or maybe both?
Both, yeah. So I love working with patients directly. We've taught a lot of diabetes education classes, which I think we'll get into in a little bit.
Sure.
I've taught a lot in an anticoagulation clinic and then in an internal medicine clinic, just going over therapeutic lifestyle changes and really focusing on diet and exercise that sometimes busy physicians, they have appointment times they have to set, don't have the time to dedicate to that. No fault of their own, of course, just the way the schedule is set up. But pharmacists often can have hour-long appointments with patients to really delve deep and then have phone consults and follow up with them and see how they're coming along, how their diet's working, and in the realm of diabetes, check in on their blood sugars and things like that. So really working one-on-one with the patient.
I'd like to come back to that too, but some of the letters after your name also include things like CDE and other letters. What does that stand for, and what kind of specialty training does that involve?
Sure. So CDE is Certified Diabetes Educator, and anyone in a health profession, so registered dietitian, nurses, pharmacists, or physicians, can become a certified diabetes educator. You need 1,000 hours of working directly with patients with diabetes. So it has to be face-to-face or virtual contact. And then you study and you take an exam that basically says, you know everything there is to know about diet, exercise, and medications related to diabetes.
The lifestyle stuff that's so important that may not be given the time at a physician's office who's doing the diagnosing, the test ordering, the follow-ups that you might get 3 or 4 per year in a good visit with your doc, but you're there, you said, as much as an hour. I know that when I'm seeing patients, I might only get 15 minutes. What sort of things do you run into insofar as the impediments to good care that the doctors can't take care of for their diabetics?
Sure. So a lot of it relates to social determinants of health, which is just kind of a fancy way of saying all of the things that aren't directly related to you and your physician's care. So things like transportation to physicians or to the pharmacy, potential cost issues with your medications, accessibility to food, and even accessibility to exercise. Do you have a safe neighborhood to go walking in? Do you have access to a pool? Do you have access to a gym? All of those things, we can kind of work with you as a patient to see what works best for you. I always like to say this isn't cookie cutter care, it's individualized patient care. And what works for one patient won't work for the next. So you really need to meet the patient where they're at, see what is affordable and accessible to them, and then make a care plan in collaboration with them.
Wow.
Welcome to Southeast Medical Group, Georgia's most awarded primary care provider. We're here for everyone, offering comprehensive care for all ages. Our services include annual checkups, chronic disease management, vaccinations and immunizations, women's and men's health services, pediatric care, geriatric care, and mental health support. With state-of-the-art facilities and a compassionate team of experts, we provide personalized care for you and your loved ones. Experience award-winning care today. Schedule your appointment now and see why we're Georgia's top choice for primary care. Southeast Medical Group, your health, our priority.
Well, if I'm a patient, I'm already thinking ahead. I want to see you, maybe even more than my doctor. How do I get to you? And what does that mean insofar as the costs, too? Because, I don't know, do I get charged for that service? And do insurance companies pay for that?
So there's actually a few different ways that a patient would get to me. One would be a provider referral, would probably be the most common. And that's a relationship that's already established between the patient's provider and myself, or whatever pharmacist is working with the provider. They would simply place a referral, I would give you a call, and then depending on the patient and what's needed at the appointment, you could either come in and see me, or we could do something over the telephone or virtual. And then depending on what is done, so if it's for a diabetes education class, there is a small cost associated with it. Most insurances do cover it. I know Medicare covers it, and then it will be up to the payer, but it's a very small fee, as well as any in-person visit with me might have a very small copay, but it would be even smaller than what a provider visit would be.
Yeah, you would think that the payers would actually promote or enjoy that kind of services, just if nothing else, to reduce the total cost of care. What is the efficacy of your cost of care reduction? Do we have any idea how well this works, this model?
Yeah, so the model's been replicated all over the nation, and the figures vary, of course, depending on the exact model and which patients you're working with. But it's been noted that a pharmacist in a provider's office can save upwards of $500,000, depending on their patient panel size.
Wow.
Yeah.
Wow. That's impressive. And I'm thinking that if we could offer this in the community, it would be ideal. I'm thinking about the state of Georgia, where we know that about 93% of the residents live within 5 miles of a clinical pharmacy. And in some cases, those are counties where there are no primary care physicians, so that their time is valuable for walk-in and even odd hours for those patients. Mm-hmm. Does a clinical pharmacist have that ability, or just like the rest of the primary care team, they're overwhelmed with care right now? What's your take on that?
I think a lot of the bigger pharmacies are very overwhelmed. So places like Walgreens, CVS, any grocery store chain. But the independent pharmacies, if you can find one in your community, often have a lot of time and a lot of extra services they can offer. So I know a lot of independent pharmacies around here, for example, can offer one-on-one counseling. They can do what's called a complete medication review, where you basically bring in a brown bag of your medication. So especially if you're on 8 or more medications, it's hard to keep up with. Sometimes you're confused what's for what are the side effects. and you just need to really sit down with a pharmacist for a while. They can do that for you, take about 45 minutes out of their day, and it's a service that's covered by Medicare for those patients that have Medicare.
So if you're the patient, just ask is really what you're
Absolutely,
saying too.
yeah.
Well, that's interesting because I know that, again, in this state and by state, there are laws that would cover their ability, indeed their scope of practice, to deliver vaccines, maybe do some testing, and render some advice about different disease states. But how does that reflect on the rest of the community that is within medicine? I'll take it one step further and make it a little controversial. Do all docs buy into this model?
I would say no right now.
Okay.
It's a little bit of a paradigm shift. So clinical pharmacy residencies started back in 1980s. They were few and far between. As I graduated personally in 2011. It was a little bit more of a push, but it was still rare. It was a smaller percentage of the class that went into residencies and did kind of this clinical model. And now it's about 40 to 50% of the pharmacy graduating class actually pursues a more clinical role. So my hope is that with that, just the more abundance of clinical pharmacists, it will be streamlined into what's known as normal care, collaborative care model. But there's still a lot of physicians that just aren't used to practicing with pharmacists and don't quite know the whole scope.
Yeah, and I think it's a great way of putting it. There's also a shortage of primary care physicians and nurse practitioners, PAs that can deliver the care that we're talking about. This will, in theory, embellish that team. And if I've said before, it's a team sport, maybe we can see an increase in access to care or the quality of that care. Yes.
I would love that. So I spent a lot of time at Grady Hospital in my previous life with patients, and a big part of my job there was actually working with them with their access to care. So some patients would tell me they were taking 4 different buses just to get to an appointment, and then they may be an hour late to their appointment due to no fault of their own. And primary care providers, as mentioned, would have, very busy schedules where they would have to say, "I'm so sorry, I'm not able to see you." So we did a lot with helping with access to care in relation to transportation, in relation to affordability of medications. There's a lot of different patient assistance programs that are available for patients that pharmacists can help them apply to. We did a lot of work with that would either reduce the cost to $0 or make it very affordable. For 3 months, they might have to spend $10 for their insulin.
Wow, yeah.
Yeah.
So talking about cost of care, especially at the pharmacy, which always seems to be a big item these days, can you maybe dive into one of those holes and tell us about some of the coupons or the assistance programs that are available?
Sure.
Yeah, as many as you know, because I know that our audience wants to know too.
Absolutely. So the first that comes to mind, which a lot of people are familiar with now, is GoodRx. You can always check that. Anybody can check that. You can go on their websites, goodrx.com, type in the medication that you're looking for and the strength. The strength is important because it actually can potentially be slightly different cost. And then how many times a day that you take it. And it will tell you, you give it a zip code, it will tell you the cheapest place near you and approximately what it will cost you cash. Now that's without insurance, of course. If you have insurance, there's a lot of patient assistance programs for those brand name medications. So you would have to actually go to whoever makes that medication. It might be Pfizer, it might be Merck, one of these big pharma companies, but they have help, especially if it's a brand new prescription for you, to see if it works for you. A lot of times they'll cover X amount for the first year and make it really affordable for you.
I'm hearing the word shop too, at least in my mind. All pharmacies accept GoodRx and other patient assistant programs, or is it, specific to the pharmacy?
It can be specific to the pharmacy. So the vast majority will accept it, but there's always those that have the right to say that they don't accept those coupons.
Okay. One of the things that occurred to me with this team-based care is the concern for oversight, especially by those physicians that are a bit reticent for accepting pharmacists in this more, I'll call it, expansive role that they have. What kind of oversight is there at the pharmacy or PharmD level?
Sure. So I've always worked in what's called a collaborative practice agreement, where the physician agrees that the pharmacist can manage these disease states with these medications and order this small set of labs and review them on your own. The physician, then everything that I would do would be documented in the patient's health record, just as if a physician would see, or a nurse practitioner PA. And the physician would be able to have access to all of those notes. And then I would escalate as needed if there was anything outside of my scope, or if I just kind of wanted to consult, I would always escalate and say, hey, Dr. Stone, this patient's blood sugars are running in the 400s regularly. Can we chat about what do you think is the best way? So there's a lot of communication back and forth, as well as really detailed documented notes that the physician's always going to read.
Mm-hmm. You used the word a couple of times now, collaborative care. Mm-hmm. It's a new model relative to a lot of other models that we've talked about. And I know that at least in Georgia, there is an oversight by licensure too. Can you talk about what needs to take place if a physician will be part of that team in the collaborative care?
Sure. So we actually recently did this here in our practice, and we came up with sort of an algorithm that is agreed upon, and then the physician simply signs their name, and everything goes to the board of pharmacy, and the board of pharmacy takes a look to make sure that the correct rules and regulations are followed, that there's very specific plans, specific oversight, and that the patient would have full understanding of the agreement, so they would fully understand that I'm a pharmacist practicing in conjunction with you, and the physician would simply sign their name as well as the pharmacist signs, and we have an agreement that we're going to work really well together.
It sounds like it's ideal for a patient's point of view. Do you have any stories about patients that you've dealt with already in this collaborative care model?
I have so many stories. How long do you have?
Probably not enough time. But we'll invite you back.
Sure. I have had patients that, one that sticks out to me, her A1C, which is just your blood sugars over 3 months. It's a number that we look at just to kind of see where you are. And when you're diagnosed with diabetes, your A1C is over 6.5. Her A1C was 15 point something, so really elevated, which means she was walking around with sugars in the 4s and 500s probably regularly. She had a lot of other issues going on, but I was able to initiate her on medications, talk to her through diet and exercise. I saw her at least every other week, every 2 weeks, which is unique for a patient to be coming into the office that often, but she needed the oversight. And I would follow up the weeks I didn't see her in person. I would call her on the phone to see how her sugars were doing. So we developed a really close relationship, and not her next A1C, which was 3 months later, but 6 months later, we had her down under 7, wow. Which, if you're not a physician, that's a lot of work. Usually that takes years to go that kind of drop.
That's a fantastic story too. And I'm glad you brought up the whole diabetes issue too, because when I left residency in 1982, 3% of the adult population was diabetic. If you look at the statistics right now, it's near to 30% who are either diabetic or pre-diabetic. Why is that important to the rest of us?
So many reasons. So one is just cost of care, right? So it's straining the health system. Patients are not eating correctly overall, not exercising appropriately, and part of that is an education piece. But in order to take care of everyone in our country, we really need to see these patients healthier, out of the hospital, and under better control. So that, it even affects the workforce. If you look at the workforce, days missed, much higher in diabetic patients because they have appointments or they're having really high sugars, really low sugars. So it affects everyone. And I like your statistic. I'll do you one better. There is the pre-diabetic patient in America. There are 90 million pre-diabetics. Of those, 80% don't know they have it. That means 80% or 78 million, give or take, are walking around not knowing that they're having elevated blood sugars or some sort of insulin resistance.
Did you know that over 80% of Americans in the US may have sleep apnea? but not even know it? Some of you may have heard from your family member or a spouse that you snore at night, or you stop breathing for a short time at night. These could be signs of sleep apnea. And sleep apnea, left untreated, can lead to more chronic conditions such as high blood pressure, diabetes, and other more severe diseases. So, what can you do? You can talk to your provider about getting a home sleep test. This test is done in the comfort of your own home in bed. All you need to do is sleep with a small device on your forehead, and your provider can review your results in about 48 hours. Come see us at Southeast Medical Group, where each of our clinics is equipped to order a home sleep test for you.
Yeah, not surprising when we see the commercials on TV for insulin resistance or metabolic syndrome or syndrome X and all the different names they give it to sell us whatever it is, including some of their naturopathic and homeopathic remedies from over the counter. All right. Well, diabetes predisposes to a lot of other diseases too, and to prevent that, well, we bring in other members of the team. Maybe you can tell us some of your experiences at Grady when you were there and what we're doing here at Southeast Medical Group as well.
Sure. So when I was at Grady, I worked in a diabetes clinic, was one of the clinics that I was assigned to, and it was a phenomenal collaborative care model. So we had endocrinologists who would pass their patients to pharmacists, who would pass their patients to dietitians. We had a podiatrist in office, and then we had someone who ran our eye exams, so you could actually go ahead and do a dilated eye
What's a
exam.
podiatrist? I don't know if everybody knows what that is.
A foot doctor. So really important when you have diabetes that you're taking care of your feet. The patient can do it on their own, so they can go ahead and check their feet daily with a mirror, looking for any cracks, any sores, and then also the foot doctor will take a look or your primary care doctor sometimes will do a test where they poke your foot to make sure that you're feeling in all the places you should be feeling.
Mm-hmm. Again, without offending the endocrinologists of the world, does everybody need an endocrinologist if you're diabetic?
No, they do not, and no offense to the endocrinologists that I know and love, but a primary care physician, especially in collaboration with a pharmacist that specializes in this, can take really good care of our diabetic patients.
Yeah, and right now, too, there is a shortage of endocrinologists, and they've got their hands on a lot of other conditions, too, that they're addressing, too. So it's my understanding that primary care actually does more diabetic care than anybody else
Absolutely.
in this country. Okay, well, let's talk a little bit more about diabetes, because that is your certified diabetic education piece that we've gotten into on the social level. And we could probably make a whole nother program on this, but there's a bunch of medications out there right now that are either expensive, controversial, or at least difficult to address. Mm-hmm. Do you want to tackle any one on your own, or do you want me to pick on one that might have something to do with Oprah Winfrey?
Let's go there.
Okay, all right. All right. Well, they call them GLP-1 inhibitors. And as I mentioned, I've been in practice for over 40 years. I've never seen anything like it before, but it's being sold as a weight loss drug now, or at least that category. There was a time several years ago that this came out as only a diabetic drug. Mm-hmm. And it's single source. That means it comes from a particular manufacturer. It's kind of one of a kind in each of the categories that it's in. So it's very expensive. Mm-hmm. How effective is it for especially type 2 diabetes?
So it is very effective. First, I like to make sure that patients understand how it works, so they understand what they're really putting into their body. So GLP-1, basically think of a hormone that does a couple different things. One of the things is it tells your pancreas to secrete insulin, or makes some insulin to help bring down your sugars. So that's how it's working for diabetes. Another thing that it does is delays gastric emptying, which means that the food you eat is going to sit in your stomach a little while longer, which tells your brain that you're full and actually helps you not want to eat as much or not desire to eat as much. And that's where the weight loss piece comes in. With that, it's not just snap of your fingers, you lost weight. There's no side effects. So that's something to consider as well. But speaking to the efficacy of it, it works really well to lower blood sugars. Mm-hmm. So you see about 1.5 to 2% drop in A1C that we referenced earlier, which is really good. And then it also, because it usually induce weight loss, it brings down blood pressure, brings down cholesterol, and can be really good for the right patient.
Boy, it sounds very positive, but it's also expensive. You and I were speaking earlier off camera about return on investment too. And there are lots of other drugs that have been out there for now decades. And without dropping the subject on that one, can we be more cost effective, more value based if we try some of those others? And can we do as well?
Yes. So metformin is the gold standard that we typically start first in a lot of our type 2 diabetes patients, as long as they don't have any contraindications. It is cheap, either it's less than $5 for everyone. I can say that with confidence. So it's cheap, very minimal side effects. Some patients do experience some GI side effects, but there's ways that we can overcome that if that does arise. And it works and works well. So that's where I always like to start with my patients. And there are plenty of other options out there where we don't have to necessarily go to a very expensive medication first.
So let's talk about standards of care. You and I, we don't just practice off the cuff based on our experience or our training per se. We follow guidelines, correct?
Yes, absolutely.
And it's confusing because there's the American Diabetic Association, there's the American Academy of Clinical Endocrinologists, there's something called HEDIS, and then all the others that put their hand into the pot and either agree or disagree. Have you found that to be confusing for you, your colleagues, or any of the patients?
I think it is confusing. I do think that across most primary care physicians, we're looking at the ADA guidelines or the American Diabetes Association guidelines. So those are the ones that I like to kind of teach off of, both to patients and providers. And really a lot of the foundational things you're going to find in both guidelines either way.
Do you ever refer your patients to the website or to the, I'll call it the interweb?
I do. I happen to absolutely adore the ADA website. If patients are interested in learning about how to count their carbohydrates or even what a carbohydrate is, what foods have carbohydrates in them, they have education for that. If they say, I really want to learn how to cook healthy, but I just don't know where to start, they have a whole section dedicated to recipes for type 2 diabetic patients. So just a wealth of information for patients on that website.
Yeah, it gets tough when you're seeing patients and they come to you already preordained in their own agenda because they went to Dr. Google and not necessarily the ADA. They've heard things about cinnamon and chromium picolinate and other nutraceuticals. What's your take on that? What you can tell our audience that might help clear that up?
Sure. So just as a pharmacist and sticking by science, I always kind of go back to what the studies show. And the answer is that there's no benefits from studies with those various supplements and vitamins.
So you could probably save them some money too, just by telling them to get the real stuff, so to speak.
Yes.
All right. Well, coming back to the GLP-1s again, I'm not going to talk about weight loss yet. We'll invite you back on another episode for that too. But are there side effects that we need to worry about with that our patients that are watching might be thinking about right now? Should I be on that? Should I do that right away as step one, or should I put that off? How do I know?
Sure. So there's a few different things that you want to think about. One is if you or a close family member has ever had thyroid cancer, because that would be a contraindication to starting it. And then another big one with GLP-1s, because of the way that it works that I previously mentioned, there are a lot of GI effects, side effects. So if you already have GI issues, that might not be a medication that you want to choose. Or if you start it and you're titrated too quickly, oftentimes those GI issues do arise and they're not mild. We'll just put it that way.
Yeah. And we've all heard stories about that too.
Yes.
All right. Well, I know there's a lot about that we'll probably hear from now on with names like Ozempic, Ribelsis, the semaglutide molecule, tirzepatide, and Mounjaro. There's probably more out there, more combination drugs that are out there. And because you're a pharmacist and a PharmD teaching others, I'd like you to teach us about some of the other things that our diabetics should be taking as a result of the diagnosis on day one, maybe.
Sure. So in addition to thinking about a patient's blood sugars, which is the most obvious thing that you think about when you think about a patient with diabetes, you have to think about all the different things that diabetes could potentially cause. So once you're diagnosed with type 2 diabetes, you're actually at a 2.5 times higher risk of stroke or heart attack. So then we're worried about your heart. One thing that's recommended in all diabetes patients, again, unless there's a contraindication, would be a statin medication, which most people have heard of for cholesterol specifically.
Names like?
Simvastatin, atorvastatin, rosuvastatin, those would all be...
Crestor, Lipitor.
Right, so those are the brand names.
Okay,
yes. Yep. And of course, there's always a reason, there could be a reason that a patient wouldn't take it if they have a contraindication with their liver, for example. But otherwise, it's really recommended all patients to be on a statin medication. And then one other thing that we're worried about with diabetes is your kidneys and kidney health.
Can I stop you right there?
Absolutely.
So if I'm diabetic and I just found out about that, but I also found out that my cholesterol was perfectly normal at that same visit, you're saying I still have to be on a statin drug?
That's what I would like to happen for you.
Okay. And the reason for that is, as you understand it?
The reason is it will reduce your risk of having a heart attack or stroke. So
Simple
we want
as
to,
that.
yep,
Yeah.
we want to keep you healthy as long as possible. And that's the way that we know how to do it right now.
Interesting. You know, there's a lot of pushback on that in social media.
Yes, there is. I would still want you on that statin if I could convince you.
Right, right. How do you go about convincing people for any of the stuff that we're talking about here?
Sure. So I like to first explain how it works. That's just where my mind goes. So I like for patients to understand that as well.
Sure.
So this is how this medication's working in your body. Because it's working like this, here are some side effects that might occur. And then here's what will happen if you take it. And here's what will happen if you don't take it. And from then, I really feel it's up to the patient to decide what they want to do.
Kind of a risk-benefit discussion, like what it took to drive to the office to find that out.
Yes,
Bad things can happen driving that car, but you're wearing a seatbelt,
absolutely.
even if you didn't need the seatbelt.
Yep,
Okay. Just so we
I
get
like
that.
it. Yes.
You like the analogies? There's a lot more coming. We'll see that in future episodes. All right. Well, I interrupted you. You said that there are other medications that if you're diabetic are very important too, not just the statins.
Yes. So first we went to heart health. Now we'll talk about kidney health. So when you have diabetes, you are more likely to have kidney issues as well. And one of the things that we like to make sure is that if you have started to have what we call albumin, or which is like a protein in your urine, that we make sure that you're on an ACE inhibitor or angiotensin blocker.
Funny names again.
Those are
You got any
big
brand
medicine names. Sure. So things like lisinopril, that would be an example. One that a lot of people have heard of, usually for blood pressure specifically. But what we do when it's for your kidney or a renal dose is we put you on kind of a lower dose if you don't need it for blood pressure. And that just helps protect your kidney and makes it live a little bit longer than it would have if we didn't have that on board.
Bless you. But did you know a single sneeze can launch up to 100,000 virus particles into the air? That's how quickly the flu can spread. And it often happens before you even feel sick. Protect yourself and your loved ones. Get your flu shot today. It's quick, easy, and covered by your insurance at any of our branches across Georgia. Visit www.mysemg.com/locations to find a location near you.
So just to clarify, once again, you said that a blood pressure pill called lisinopril should be taken by diabetics on initiation of diagnosis, even if their blood pressure is okay.
Even if their blood pressure is okay. Now, I will take a look at kidney labs to see if it's appropriate. But yes, that would be the recommendation.
Okay. All right. It can be confusing. And
It
so that's
can
why I
be.
asked those
It
questions.
absolutely can be.
Yeah. We often get pushback in my offices. I'm sure you do in yours as
Yes.
well. Anything else recommended? I know there's one controversial drug that has been around for decades.
Are you referring to aspirin?
I'm referring to aspirin. Why does it seem to change from decade to decade? And what's the current recommendation? Maybe you can tell us why.
Sure. So the absolute most current recommendation is that it is recommended in patients with some ASCVD risk, which is just cardiovascular risk, but under the age of 60 is the latest. So anybody over 60, they're now analyzing risk versus benefits, which is what we're always doing. And as you mentioned, it does kind of change every decade whether or not you should be on this small pill that's been around forever. But the absolute latest study recommendation is over the age of 60 is very patient dependent because of potential GI issues with taking a little tiny baby aspirin.
Yeah, just a baby aspirin.
Yep.
In that high-risk diabetic patient. Well, they say we're practicing medicine and one day we'll get it right. Maybe one day we'll get that aspirin dogmatically clear to everybody.
Yes.
And you also mentioned the whole concept of tailored care.
Yes.
So there's lots of categories that we talked about with the diabetic. And we might want to touch on type 1 diabetics now too. In other words, there's a difference between the two, and maybe you can spell that out. And how do you play a role in the type 1 category?
Sure. So that's a question I get a lot from patients when they're first diagnosed. They want to know, am I type 1 or type 2? Chances are most patients that are diagnosed later in life are going to be a type 2 patient, and patients that are diagnosed at an early age are type 1 patients. Type 1 patients, their body doesn't make any insulin at all. So oftentimes, and sadly, a lot of times children end up potentially in the ER because they're having these symptoms of having really high blood sugars, and they didn't know previous to that they had type 1 diabetes. Because their body and their pancreas isn't making any insulin at all, the only way to bring their sugars down is to give them external insulin. So they have to actually inject insulin or use an insulin pump. And then a lot of type 1s also will use what's called a continuous glucose monitor. So instead of having to go in and prick their finger all the time like some type 2s do, they just wear something that continuously reads what their blood sugar is, which is really nice.
And then does it provide insulin as well too? Is it a feedback loop?
It can be. So there are continuous glucose monitors that pair with insulin pumps, and it will then tell your body how much insulin, or tell your pump, how much insulin to give your body.
That's fascinating
So
technology.
it's really advanced lately. It's really interesting.
I think what we'll do is save that for a future episode.
Sure.
But since the vast majority of our diabetics, on the order of 90 to 95%, are type 2s, I'll rest on that for a while too. Can a type 2 become a type 1?
Well, that's an interesting question. For clarity's sake, we'll say no. So a type 2 is a type 2 once diagnosed. And most of the time, unless your A1C or blood sugars were really, really high, you won't start with insulin when you're type 2. First, we'll try some oral medications to see how those work. And then over time, should those medications fail, you may need insulin. But that doesn't mean that you're a type 1. It just means that we've kind of exhausted other options, and now this is what your body needs.
Well, if your body needs insulin, why not just start with insulin? What's the deal there?
So insulin is very cumbersome to go from not taking it all to having to know what your sugar is before you eat each meal to know how much insulin to inject. Also, there's low blood sugars associated with insulin. So what we call hypoglycemia is low blood sugars. And patients have to be a lot more concerned about low blood sugars when they're taking insulin. And then lastly, just the ease of taking some of our oral medications and cost as well.
I understand that while we were talking about those other GLP-1s, the Ozempics and the semaglutides of the world, those were weight loss. Insulin tends to be a weight gaining drug too, correct?
You can gain some weight with insulin. It's important to understand, typically it's a very small amount in relation to what you're thinking about with weight gain. So most patients might see somewhere around a 5-pound weight gain. And predominantly it does tend to be in the abdomen. So that is a side effect. But overall, if your body needs insulin, then that's the medication you need. And it will bring down your sugars. And you can kind of circumvent the weight loss the weight gain with doing a lot of therapeutic lifestyle changes and negate some of that.
Yeah, so kind of put it off until it's at that point when you really do need to have it at that point too. All right. You brought up the whole idea of a continuous glucose monitor. Can you tell us more about what's available and when it should be prescribed? Should it be prescribed for everybody?
I would love that.
Okay.
Unfortunately, insurance payers aren't quite there yet with everybody needing a continuous glucose monitor. I think for type 1 patients, as we discussed, that would be a great option. Type 2 patients, if you're on insulin, it's great as well because we do have to worry a lot more about those low blood sugars.
Interesting. Have you ever worn one? Have you ever tested?
I personally haven't. Have you?
I have.
Yeah.
I wore it on holiday too, which was probably the wrong thing to do because, well, I'll fess up. This is an anecdote for myself. I'm from the northeastern United States, and there's something up there that we use for dessert called whoopie pies. Do you know what a whoopie pie is?
I do.
They sell them in Savannah too, but they're not the same as the Northeast.
Okay.
So I was wearing my continuous glucose monitor so that I could empathize with my patients and understand a little bit more about my day. And it woke me during the night with some low blood sugars, which was interesting, but you could turn off the alarms. Well, we were vacationing, as I mentioned, and I had a whoopie pie. And in that first hour, I was proudly displaying my sugar on the continuous glucose monitor that was in the 100 to 125 range, we'll say. But at about an hour and a half, mine went to almost 200. I don't eat as many whoopie pies as I used to eat anymore. But what it taught me is that we're all subject to those kind of excursions. And maybe somewhere, as my father and my grandmother were type 2 diabetics, I'm on my way to being there as well too. So I've just got to be a little bit more careful. It taught me something as a, quote, non-diabetic that I didn't know beforehand. Imagine what it could do for all of my diabetic, insulin-resistant, obese patients if they could just read their blood sugar continuously.
Yes, I agree. And your story reminded me of a patient story where I was working with her. I did full diabetes education classes, so she had the nutrition content, and she told me she was eating healthy. She promised she was eating healthy, but her sugars were still elevated. And come to find out, I did food diaries with her, that she was eating a smoothie every morning and putting about 10 different fruits into the blender, blending it up, and it was bringing her sugars really, really high every morning. And had she been wearing a continuous glucose monitor, she maybe could have correlated that, or I could have correlated that her breakfast was what was really bringing her up because her lunch and dinners were, lean protein and vegetables as we described. So interesting and really revolutionary, I think, for our type 2s and even some prediabetes patients. They're trying them out now in some trials to kind of teach them when you eat this is what happens to your sugar.
So if there are any payers watching, we'll put in a pitch for getting continuous glucose monitors for all of our people to qualify in that category.
Yes.
The return on investment is high.
Yes.
And don't eat whoopie pies if you want to keep your sugar low. Don't eat whoopie pies. That's the message. When we are monitoring people now, we have a whole slew of what I call remote patient monitors. Do these CGMs, for short, continuous glucose monitors, actually go to my doctor's office? Or how does the data get there? Yes, so the data is linked to your doctor's office. There's codes and things that you'll input, but the data will go straight to whoever's monitoring you, whether that's a physician, nurse practitioner, PA, or pharmacist. And they will get alerts as well when you're having continuous elevated blood sugars or if you're having lows where it drops really low. Does your team then flag that somehow, or do you wait for the next office visit to find out? So often it will be flagged, especially if it's on an extreme end, and then somebody should call you and act on that information. Interesting. So a part of that collaborative care model, once again, where the physicians don't necessarily have time to empty their in-basket of all of that data that's pouring in on a daily basis, your team can analyze that and get the feedback to the patient and or the provider to adjust the medications. Yes. Or you can too. Yes, absolutely. And I forgot to ask if you can adjust insulin doses too on your patients as well.
Yes. So under the collaborative practice that we talked about, any medication that's listed in there, so if it was for diabetes, any diabetic medication is listed, we can initiate, titrate, or discontinue as needed.
Interesting.
Yes.
What does titrate mean?
So titrate would be if an insulin patient came in and let's say we started you at 10 units and then we saw that your sugars were elevated, we would increase your dose, or we might teach you how to increase your dose on your own. And then we'll call you in a couple weeks and check in. And then if we need to increase it again. And then the goal is that by the time you went back to your primary care doctor, because we're not going to take you away from them, we just want to be the support in between those appointments, that you would see a much lower blood sugar versus if you just stayed at 10 units and came back in 3 months.
There's some great fruits out there, and you are versed in nutritional advice. Aren't fruits natural? Aren't they good for you?
They are good for you. And I always tell my patients, I don't want you to stop eating fruit, but I do want you to understand that fruit has carbohydrate content, and carbohydrates make your sugars go up. So if you eat a lot of fruit, you are going to see an increase in sugars.
Okay. So are carbohydrates evil? Should we just cut out and go on a keto diet or an Atkins diet and just give up carbohydrates? What's the rule on that?
Carbohydrates aren't evil. Your body does need them. It uses them for good things like energy and fuel to keep going throughout the day. So we do still need carbohydrates. It's just moderation like everything else. So there's a certain amount that you should eat per meal. And then, of course, I always like to tell my patients, if you think about carbohydrates, bread, rice, pasta, the white versions, those are going to just have more carbohydrate content. So the brown rice, brown pasta, anything that's whole wheat, that's going to be better for you, have a higher fiber content and a little bit lower carbohydrate content.
Mm-hmm. So you said that this was a bit of a surprise to you when this one patient told you about her smoothie in the morning. How do you find out about their diet? How do you delve into their personal lifestyle and diet plans?
So that's going to be very patient dependent, but what I started doing, which I really grasped onto, was a 24-hour recall. So you don't even have to bring in all of your food logs. While that would be great, it's not for every patient. A lot of patients lead very busy lives and they can't detail every single meal they eat. But just tell me about what you ate yesterday, from the time you woke up till the time you went to bed, and then tell me if that's a typical day for you or not. And we'll go from there. We'll talk about each part of that diet. So we're going to start with your orange juice and coffee, and we'll talk about that carbohydrate content. We'll talk about the salad you had for lunch and the pizza you had for dinner, and just kind of go from there. And then each visit, you gain just a little bit more knowledge about all the different pieces that are playing into your daily food intake.
Are there any resources that they can do on their own, apps on their phone, things like that, that might help with that?
Oh, absolutely. There's MyFitnessPal is one of my favorite. No relation. I'm not promoting them. Just it's really great because you can simply scan barcodes and it gives you all the nutritional information. And then it kind of tells you where you are in the range throughout the day. If you've had too many carbohydrates, not enough protein, too much sodium even. So that's one of my favorites. But there's a lot out there like that.
Wow, just a wealth of knowledge. Thank you for that. I really appreciate that too.
Mm-hmm.
Is there any question that I haven't asked you about diabetes that is a message you'd like to get out to the general population?
That's a great question, Dr. Stone. So I think that a diagnosis of diabetes is scary for a lot of patients, and they may not hear everything at their first visit because it's a shock. And it's a total lifestyle change, and it has to be. If you want to continue to live a healthy life, you need to change the way you're doing things, which is very difficult for a lot of patients that have done things a certain way for a very long time. And it doesn't have to happen at once, and it doesn't have to happen 100% of the time. So I like to set really small, attainable goals, work on those little bits at a time, and then just always remembering kind of the 80-20 rule. If you live this way 80% of the time, you can have a moon pie maybe once a month or so.
Thank God for that. I'm going on vacation in a couple of weeks, and I may slip in a little bit of whoopie pie again as well. That's excellent. What motivated you? Why did you come into medicine? You said something about teaching.
Yes.
But more? Tell me.
Sure. So it's a long, twisty story, but I was in college for elementary education, And I've always just sort of excelled at math and science, and I was bored in those classrooms that I was sitting in, and ended up wanting to pursue something more in the science realm. And I don't like blood, to be honest. I didn't want to work in nursing, and I didn't want to be a doctor. My mom actually was a pharmacist, and I found it interesting just learning how drugs work in the body and why you would take something over something else. And then I've always just loved working with patients. I've loved that education piece of taking somebody from being scared of something to really understanding what's going on in their body, why a medication might be good for them or might not be good for them. And then, working collaboratively with that patient to come up with a care plan. It's always kind of just drove me to help the community and help each patient individually.
Yeah. Well, thank you. We're better off because of the career path that you've chosen. And I want to thank you for being a guest here as well. The only other thought that I had while you were telling me that, why the focus on diabetes? We know the economic impact on the country. Mm-hmm. Was it in your family? Is it something that was motivated there?
It actually was not really in my family. It was just something I knew was extremely prevalent in the community, and especially the community I was doing my residency in at the time had a lot of what we talked about earlier, kind of social determinants of health problems going on. And it was just a way that I really saw my impact, and I was able to help the community in a bigger way. We were able to not only control blood sugars, but get patients on some of those medications to prevent cardiovascular events or prevent problems with their kidney, prevent their eyes from going bad. A lot of different things went into consideration there, but I developed a passion for it and really enjoyed working with patients over time.
An idea, a thought that we haven't gone down is prevalent in Southeast Medical Group, that the delivery of preventative care reduces the cost curve overall in the community. Mm-hmm. And that there are incentives in medicine these days that don't necessarily follow that. In other words, we emphasize the disease state, not the healthy state. Mm-hmm. What can you tell me about value-based care and maybe what you know about the, I'll call it, efforts on population health?
Sure. So population health is a whole can of worms we could go into, but really what it boils down to is making sure patients are healthy, doing the right things to prevent events. So we don't want to see you after you go to the emergency room or hospital. We want to prevent you from getting there. And then there's certain measures that are set up to ensure or ideally prevent you from getting there in the first place. And we focus on those. We want to make sure that our patients are taking things to prevent heart attacks and strokes, like we mentioned. We want to make sure that patients are getting screenings done. So things like a mammogram or colonoscopy, where we could early detect things, just to give you that whole picture of the patient and prevent potential complications down the line.
Yeah. Well, don't we do that in what I call fee-for-service medicine anyway, or no? You tell me.
We do some of that, right? Mm-hmm. But at the end of the day, fee-for-service is a certain goal. It's getting a patient in for something, treating that issue, and maybe not looking at all the different pieces that could take place down the road, that could prevent something down the road. It's just a harder model to get that whole picture, I think, sometimes.
Yeah, I don't think they pay for social determinants of health and the time spent to do that. They don't pay for counseling for a lot of things that you talked about in this episode to reduce the cost of care. But if you're a provider, then how does value-based care play into the future?
I think value-based care is the future. It has to be. It has to be the direction that every provider is going, because CMS says so, to be honest.
There is that force, that incentive, yes.
So that's a huge part of it. But no, it's the right thing to do by the patient. If you went into medicine to help people and to keep them healthy, then value-based care is the road that you want to go down. Right.
And we're getting paid for all the touches that you talked about, the nutritionist, the eye doctor, the foot doctor, the PharmD, the entire certified diabetic education realm that we've covered this time as well, too. And the docs, at some level, will get paid better in value-based care than we do right now.
Right.
Okay.
And it's all about just hitting those marks of keeping your patients healthy and keeping them doing their preventative things that they need to do to keep themselves healthy.
And if you had to pick a disease state in this country that you would target first, it would be?
Diabetes.
Diabetes. Very good. Hey, HealthCast Southeast is proud to bring you our presentations, and we'd like to bring you more. Now we need to know what you want. I hope you've enjoyed the episodes that you've seen so far, and to that end we have a QR scan code that's on the screen. Please take the time, if you will, to complete that. Give us the feedback and we'll send you what you want. We're looking forward to more episodes just like the ones that you've seen. And for now, have a great day. Well, that'll be it for this episode. Thank you for answering all of my questions, and thank you for being a guest on this episode. She's been a wealth of knowledge, and we look forward to future episodes, and maybe I'll invite her back as well, too. There's so much to be learned. And thank you, audience, for tuning in to HealthCast Southeast. I'd like to thank my production team. I'd like to thank Southeast Medical Group for underwriting and promoting this. We hope you enjoyed it, and if there's any kind of feedback for us, tap the QR code and be in touch. Till the next episode, bye.